So we are on types of migraine. So we have common migraine, classical migraine, hemiplegic migraine, basilar migraine, ophthalmoplegic migraine, or acephalic migraine, right? So in common migraine, common people don't have any aura, right? So it will be only headache, no aura. And when it's classical means a person who is classical, right? So classical people have a headache also plus aura also because they are auratic people, right? Then comes hemiplegic. Whenever it's hemiplegic, that means there will be migraine which will be followed by extreme weakness of limbs, right? That will be hemiplegic. Whenever it's basilar means migraine will be there, but along with what? Tinnitus and vertigo. Then comes ophthalmoplegic. That means migraine will be there, but there will be a palsy. So which nerve will be there? Third nerve palsy. So in ophthalmoplegic, there will be third nerve palsy along with migraine. Then comes acephalic migraine. In this acephalic migraine, in this there will be no headache, only aura will be there. Okay. So this was the thing in the types of migraine. Then we can see the diagnosis, right? In diagnosis, what do we have here is first we can see it will be unilateral. Okay, second it will be moderate to severe. Okay, throbbing or pulsatile, or 4 to 72 hours. Okay, if it is like this, so keep it in one column. Second is photophobia or phonophobia, keep it in another column. Third is nausea or vomiting. So or any of these three columns if present, then that will lead to diagnosis of the migraine, right? Then comes how do we treat it, right? In treatment, what we can do in whenever it's acute attack, that then it will be NSAIDs, right? In NSAIDs, it will be like PCM, indomethacin, naproxen. Okay. Then second, it will be sumatriptans. That will be drug of choice, right? But in sumatriptans, it will be contraindicated in pregnancy. Okay. Third will be ergotamine. Fourth will be caffeine, right? So this all are the treatment in this. And also, if you want to see the prophylaxis, then it will be propanolol, TCA, SSRI, gabapentin, verapamil. So all those things will be the prophylaxis, right? Then we can also have some new drugs which are like CGRP, which I told in migraine. So in this it will be like Gepant, right? So it will like UBRO, Abrogepant, RIMI, Rimigepant, okay? And all other can be monoclonal antibodies, right? Then also in this there could be like headache medicamentosa or medication overuse headache. There could be exercise induced headache, cough headache, postcoital headache. Okay, all these things can be there, right? Then it comes about if you want to know little more, but yeah, we can know about Lennox-Gastaut syndrome, what it is. This usually comes in this, there will be multiple seizure types. It could be like GTCS, clonic, atonic, all these things can be there. In this there will be ECG which will be less than 3 hertz spikes, right? And then in this there will be impaired cognitive function. So these all were the things about headache. Now let's come to epilepsy. What is epilepsy? In this there will be seizures first, right? So what is seizure? Seizure is hyposynchronous discharge due to electrical activity in brain. In epilepsy, it will be 2 or more unprovoked seizure. Whenever you have 2 or more unprovoked seizure, that means it is epilepsy, which we also call as Mirgi, right? Okay, so now let's see the EEG. In this, the EEG can be there could be some. For example, we can have gamma, beta, alpha, theta, and delta, right? So we can use a mnemonic like G bet dance, right? So G is gamma, okay. Bet means beta, beta means eyes open, okay. A means alpha, alpha means relax, awake but eyes closed. This question has also come. Okay, in alpha, then comes T, that is theta. Theta means deep relaxed meditation. Then comes delta. Delta means deep sleep. So these are all the things which comes under ECG. So most common cause in pediatrics, it will be febrile seizures. Okay, and whenever it's most common cause in epilepsy, then it will be like whenever if it is less than 35, that then it will be trauma. If it is more than 35, then it will be CVD, cerebrovascular disease, right? In epilepsy, we have 3 types. Okay, first of all, it could be like focal or partial. Second, it will be generalized. Third, it will be focal along with secondary generalized, right? So what do we have in focal? In focal, we can have Jacksonian march. Okay, we can have Todd's palsy. We can have EPC, epileptica partialis continua. Okay, fourth one, it could be mesangial temporal epilepsy. Okay, all these things can be there. So Jacksonian march, that means there will be distal to proximal. This question has also come. once. Okay, then it's Todd palsy. Where is Todd's palsy? That will be generalized weakness, extreme generalized weakness, right? And whenever it's EPC, epilepsy, partially continuous means seizures have occurred more than 24 hours. Okay, and when fourth one is mesangial temporal epilepsy, that means mesangial, in this there will be refractory seizures or hippocampal sclerosis, right? So in this, what is the treatment of focal one, right? So in this there could be, or for the mesangial one, we can use hippocampectomy. Okay, we can use corpus callosotomy, right? These two can be there. Then comes the generalized. This seems to be the most common. Okay, in this there could be absence seizure. Okay, for example, child going to school and suddenly he did blackout. Okay, and sometimes low grade in school. Okay, and it is first noticed by a school teacher. Okay, and in this, if it is hypoxia or hyperventilation, there could be provoked seizures. Okay, there could be no clonus or no loss of consciousness, no post ictal deficit. All these things can be there in the absence seizures. Okay, then comes diagnosis. In diagnosis there will be EEG. Okay, but the EEG will be how much, 2 to 4 hertz. Okay, and this will be spike and dome pattern. Okay, in this the diagnosis could be like, see, we know the seizures, right? But how we will be able to know whether it's a typical seizure or it's absent seizure? Okay, so in typical one the IQ will be normal. Okay, and in this there will be 2 to 4 hertz. Okay, and the treatment we can do is ethosuximide or valproate, right? But whenever it's atypical, whenever it's not typical, that means the IQ will be low. Okay, and hertz, in typical it was 2 to 4, but here it will be less than 2 to 2.5 hertz, right? Here also it will be valproate, but it will be associated with tuberous sclerosis. Okay, so this was the thing. And now let's talk about myoclonic. So this was the one which I told about general things. Now let's see about what is myoclonic. So in the myoclonic, it will be both focal and generalized seizures. First of all, okay, in this there will be preserved consciousness. Okay, in this there will be jerky movement, sudden. Okay, in this there will be preserved postural controls. Okay, and now the main thing, how and in which type of it will be seen. It will be seen in adolescents, hyperventilation or decreased sleep. In this there will be early morning along with strong jerks. In this there will be hereditary form, Jenks syndrome or JME. Okay, we also call this Lefora bodies. In this there will be 4 to 6 hertz. Treatment will be valproate. So this was the myoclonic, right? Then comes atonic. What is atonic? Atonic is seizures will be there along followed by atonia. Okay, in this there will be sudden loss of postural control. Okay, and also in this there will be regain consciousness, right? Then comes GTCS. It is the one which is most common in IPD. Okay, and in this there will be what, convulsions can be there, tone will increase, uprolling of the eyes, frothing, bad smell, spontaneous urination, spontaneous defecation, post-ictal cry, confusion. In this there will be loss of consciousness, post-ictal deficit. Okay, all these things will be there in it. And also in this the treatment will be valproate. Okay, then comes what? Then comes let's see the yeah, we can see what is cannabidiol. Cannabidiol is the one which is a product of cannabis as a oral solution. In this there will be Dravet syndrome, tuberculosis sclerosis, J0, Lennon-Gestot syndrome. All these things will be there, right? And then we can see what is status epilepticus management. In this the management will be lorazepam. Okay, loading dose of anti-epileptic drug, thiopentone, propofol. Okay, and then there will be we can see whenever the drug epileptic stops, then there will be no seizures in the last 2 years. When we see the taper the base, stop AED, these things will be there, right? And now what we can do is we can know, like, at the end, see, we have all the things, but for example if we have tonic, clonic, myoclonic, atonic, GTCS and atypical. Okay, all these things are there, but in all these things that drug of choice will be valproate. Okay, only except 2 things. Whenever it's typical means in typical absence seizure, what we do is ethosuximide, which will be more than valproate. Second one is focal seizure. Focal will be carbamazepine. Only these two things are there. Otherwise, in rest, all are valproate only, drug of choice, right? Then comes pregnancy. So in pregnancy, what happens is pregnancy induced seizures and epilepsy in pregnancy, right? So whenever you have pregnancy induced seizures, that will be eclampsia. So in the treatment will be MgSO4, magnesium sulfate. And whenever you have epilepsy in pregnancy, in that continue the same treatment plus one folic dose, right? Yeah, we give this. And so this is the one. And what drugs are safe in pregnancy? That will be levetiracetam, okay, lamotrigine, phenobarbital, like this. Okay, now let's see the bodies. Okay, for example, if someone asks me what are Hirano bodies, okay, Hirano bodies will be Alzheimer's. What are Lafora bodies? Lafora bodies means JME. What is Lewy body? Lewy body means Parkinson's. What is pink bodies? Pink body means pigs. What is Negri bodies? Negri body means rabies. So all these things will be there. Then what is Rett syndrome? Rett syndrome is tropheximite, right? Then we have keto diet. What is keto diet? It is the one which is safe in pregnancy. Fat will be high, carbohydrate will be low. Okay. Then what is infantile spasm? We know salam seizures, right? Yeah. So in this there will be hips arrhythmia. ACTH is the drug of choice, and this will be associated with tuberous sclerosis, which will be vigabatrin, right? So these were all the things. Now just I will be telling you all the ECG with the EEG with the which we have studied till now. Okay, whenever we have typical seizures, that will be 2 to 4. Okay, whenever you have atypical absence seizures, okay, in this it will be less than 2.5. Whenever we have myoclonic atypical, in the myoclonic seizures, what it was 4 to 6. Okay, whenever we have infantile spasm, that will be hips arrhythmia. Whenever we have herpes encephalitis, that will be PLAD. And whenever we have hepatic encephalopathy, that will be triphasic wave. Okay, whenever we have coma, that will be burst. And whenever we have CJD, that will be periodic sharp, right? Okay, now yeah, just two more things. Whenever you have epilepsy in menses, then it will be catamenial epilepsy. Whenever it will be sudden outburst of energy, laughing or crying, that it will be gelastic seizure. Okay, so these were all the things. Now come to West syndrome. What is West syndrome? It will be infantile spasm, EEG, hips arrhythmia, or neurodevelopment regression. So this was all about hips arrhythmia. Sorry, in West syndrome, right? Then comes ANS. What is ANS? It is related to CNS and PNS. CNS is the one in which there will be oligodendrocyte, right? MS. PNS is the one which has Schwann cells, right? So first what we have is multiple sclerosis. Then we have SSBE, subacute sclerosis, pain, encephalitis, that will be measles. Then we have PMLE, progressive multifocal neuroencephalopathy, then that is like JC virus and HIV. Then we have CPM, central pontine myelinolysis, that will be rapid correction of hyponatremia. Then leukodystrophins, loss of myelin, only in form of white matter, right? Yeah, so these were all the things. And we all know what is node of Ranvier. Okay, whenever its muscles is slow, that means it is due to myelin sheath loss. Okay, then we have a neuromyelitic optica, okay, or DeVig disease, that means it is a demyelinating disorder due to recurrent attack of optic neuritis or myelitis. Then we have tygroid white matter, okay, that means Pelizaeus Merzbacker's disease. Okay, these were the things. Now let's come to multiple sclerosis. In multiple sclerosis, this is the one which is the most common demyelinating disease. This is autoimmune. In this, it will be more than female than male. Okay, most common time is relapsing. It relapses. Okay, its hallmark is demyelination. Okay, okay. Now, what do we need to know is most common things are sensory complaints, optic neuritis. Okay, motor complaints, bowel or bladder involvement. Main is spinal cord. Okay, then we have a sign, Lemaitre sign, that is flexion of neck which produce electric shock. Okay, then we have Earth-Tofts phenomena. Then we have facial myopsia. Okay, then like we have nerve palsy 5, 7 and 9, trigeminal glossopharyngeal. Okay, these are all the things of multiple sclerosis. Then is EDSS, which is expanded disability status scale. Okay, expanded disability status scale for the multiple sclerosis. In this, there will be neurological symptoms. Normal is less than 3.5. It is more than, if it is more than 5.5, then it's neurological impairment, and if it is 10, then it's death, right? So this were all the things. Then is AIDP, acquired immune demyelinating polyneuropathies. Okay, so these were the things. Now let's see. Yeah, in the acquired immune demyelinating neuropathies I told, then comes GBS. Okay, in this what do we have is relapsing remitting relapse, which is most common. Then we have primary progressive, which is worst prognosis. Then we have secondary progressive. Then we have benign type, which is the best prognosis. Best prognosis. Then we have MRI. In MRI, what do we see? We see Dawson's fingers. In CSF, we see McDonald's criteria. Yeah, McDonald's criteria. This is very important. Okay, and yeah, now let's see GBS. Okay, and no, first see that let's see the all the scales, then we see drug of choice, and then we move forward to GBS, right? So where we have Midas score, M is means migraine, Midas score means migraine. Then we have cage questionnaire, cage, which I already told in one of my previous videos. Cage means alcohol, means cage questionnaire, alcohol addiction. Then MMSE means M, so dementia, DEMENTIA, so dementia, take M to M. Okay, so it will be in dementia. Then we have UK PDS criterion and Braque staging, that will be Parkinsonism. Okay, Osman grading, that is myasthenia. Then we have McDonald's criteria, most important. McDonald's means MS means multiple sclerosis. Then we have Brighton's criteria, ICH score, H and Shunt score, HAS. Then we have ABCD2 score, that is to protect future of risk of stroke in transient ischemic stroke. This has also come. Drug of choices, steroid, methylprednisolone. Then we have interferon beta. Then we have alpha and gamma. Alpha means hepatitis B, C, and D. Gamma means granulomatous disease, right? Then we have natalizumab. So this were all the things. Now let's go to GBS. GBS is what? Patient will have a history of GI and respiratory tract infection with pathogen like, see, GI will be there, respiratory tract infection will be there, along with Campylobacter jejuni, which is the most common, right? That will be in this. There will be CMV, EBV, COVID-19, mycoplasma. Okay, ascending polyradicular neuropathy. In this, we will have types. Types will be acute and chronic. Okay, in acute will be less than 8 weeks. Chronic will be more than 8 weeks. Okay, in chronic it will be IgG antibody. Okay, then comes in acute, we have AIDP, acute motor axonal neuropathy, AIDP. Then we have AMAN, then we have AMSAN, then we have Miller-Fisher. Okay, so these were things which are acute. Then we have chronic. In chronic we have CIDP. Okay, yeah, so in acute GBS, what we give O2, IVIG. Okay, plasma exchange, and steroids have no role, right? And when we go to chronic one, in chronic we have steroids, we give high dose IVIG, plasma pheresis, glucocorticoids, all these things we give, right? So now what is Miller-Fisher, which is in acute GBS? In Miller-Fisher we have AAO. Okay, that is ataxia, areflexia, ophthalmoplegia. Okay, and then what we have is GOA, that is ataxia, hyperreflexia, and ophthalmoplegia, right? So usually both of them, in both of the triads, ataxia is same, ophthalmoplegia is same. Okay, but areflexia in Miller-Fisher it will be areflexia, and in second one it will be hyperreflexia, right? Then in GBS we can have some symptoms, like how do we diagnose it? So first of all, like things are like IgE will be involved, which I told. Okay, there will be loss of proprioception, lower cranial nerve. Okay, postural hypotension will be there. Symptoms will be what? Symptoms will be radicular pain in back. Okay, weakness will start from lower limb and it will move upward. Okay, lower limb to move upward. There will be lower limb, so in this there will be back or trunk, and upper limb and face it will be diaphragm. Okay, in diaphragm it will be respiratory muscle paralysis that will lead to death. Okay, in this then there will be quadriplegia, paraplegia, cerebellum, higher mental functions, bilateral, cerebral palsy. Okay, so yeah, so now in this what can we do is we can do lumbar puncture, In lumbar puncture, usually it's expected this also question to come. In this there will be albuminocytological dissociation. That means in this the protein will be increased but cell count will remain normal. So this is what the GBS is. Then comes what is Horner syndrome. Horner syndrome means Punjabi meal. Punjabi means P. P means ptosis. Meal means M. M is meiosis. E means enophthalmosis. A means anhydrosis. L is loss of ciliospinal reflex. Right? Just give me one moment and then we start from memory and dementia. So we have short-term memory and long-term memory. Okay. So what do we know here is we have long-term memory. In long-term memory, we have two things. Either it's explicit declarative or implicit and non-declarative, right? Whenever it's explicit or declarative means declaring. In this there will be two things. Either it will be episodic or event, or it will be semantic, fact, place or person. That will be long term. In that, second is implicit. In implicit, which is non-declarating, that will be conditioned. For example, in this there will be two things, either classical conditioning or operant conditioning. Classical condition is like Pavlov, which we know the example of a dog. And in the operant conditioning, that will be of Skinner, like reward, punish. Like, we have food, okay, like we have a rat and we reward and punish. So that will be of the operant conditioning of a rat, right? Now comes hydrocephalus. So what is normal pressure of hydrocephalus? We will have dementia, we will have urinary incontinence, we will have ataxia. Okay. In this, the action potential will be increased. Then it will be increasing of the depolarization, which will lead to increase in calcium. Okay, calcium means strengthening to synapse. Okay. Whenever we have loss of memory, then it will be amnesia. Whenever we have amnesia plus any of the cognitive defect, then that will be dementia. Because amnesia was only loss of memory, but along with the loss of memory, you have a cognitive defect, that is dementia. Okay. Now the most common cause of dementia, that will be Alzheimer's, right? Okay. Now two things are there. Either it will be reversible or irreversible. Either it will be cortical or subcortical. Okay. So whenever you have reversible, in reversible, you can have deficiency, you can have toxicity. In this, it could be like B1 Wernicke's Korsakoff, it could be B12 subacute combined degeneration, it could be B3 pellagra, hypothyroidism, heavy meal, normal pressure, hydrocephalus. All these things can be there, right? Now, when it comes to irreversible, in irreversible, it will be like neurodegenerative. Okay, in the neurodegenerative, it will be like Alzheimer's, we can have, which is short-term memory loss. We can have Parkinsonism, we have Huntington's. Okay, and in this there could be dementia with Lewy body, that can be associated with visual hallucination. Then we can have Pick's disease. In this there it will be frontotemporal dementia or personality change. Then we have CJD, Creutzfeldt-Jakob or Prion disease. In this there will be behavioral changes. So okay, so all these things will be in the irreversible side. Okay, in reversible we have only B1, B12, B3. Okay, and now comes to cortical and subcortical. Cortical will have more severe. For we have a mnemonic: Amit, please choose fruits. Amit is Alzheimer. Please is Pick's. Choose means CJD. Creutzfeldt-Jakob. Okay, and F is fruits means frontotemporal disease. And in subcortical, all less severe, all others will come here, right? Okay. So in the B6, which is pyridoxine, in this there will be what? Usually ATT. Okay, this will prevent peripheral neuropathy. Okay, in this there could be in peripheral neuropathy. In this there could be hereditary neuropathy also. That name will be Charcot-Marie-Tooth, CMT. Okay, and whenever it will be more like peripheral neuropathy and ATT, all these things will be more. It will be DSP and distal symmetric sensory and motor neuropathy. Okay, and whenever it will be diabetic, so treatment will be dolutegectin. Okay, so these are all the things. Now let's talk about the Alzheimer's disease. What is Alzheimer's? Okay. So in the Alzheimer's, first of all, it's the most common cause of dementia. In this, there will be three things. It will be like penicillin 1, penicillin 2, APP, APOE mutation, right? So in this, it will be like penicillin 1 more than 60 to 65. In this, there is a protein called TAU tau. Okay, and in this, it will be like we will have NF tangles which will be proportional to severity. We have alpha beta. In alpha beta, it will be neuritic plague and amyloid angiopathy. Okay, in Alzheimer's, we have risk factor and protective factor. In the risk factors, we have age, down, repeating head trauma, less education, and smoking. All these things will be a part of risk factors. In the protective factors, we can have higher educations, puzzles, chess, sudoku, okay, and learning new languages. So these are the protective factors. Okay, main are higher education and learning new languages. Okay, and before this also, which I told out, like tau protein, alpha beta, and NF tangles proportional to severity. Sorry. Then in this we have diagnosis. In diagnosis we can have MMSE. This is very important. Mini mental state examination. This is the investigation of choice in Alzheimer's. And also in MRI we can see cortical atrophy, which is normal chance in elderly. Then we have is treatment: donepezil, rivastigmine, memantine, tecarine. Okay. Then we have CJD, which is prion disease. So in prion disease, which we already know. So in this, it will be like, first of all, it will be infectious protein. It will be rapid progressive dementia. Okay, and in this there will be PRPC disease. It will be like positive. Then this will deposit the same. Okay, and in this it will be like human cannibalism and infective cornea. And in this bi or triphasic discharge will be there. In this there is no treatment. 6 months, like it will be loss of all the memory, and after 1 year it can lead to death. Then comes Wernicke-Korsakoff. In this it will be like Goa. Okay, so Goa is global confusion, ophthalmicus, nystagmus, age, ataxia, amnesia, articulating, all these things. And whenever it's Korsakoff, in Korsakoff it will be like we have cap, so it will be like confabulation and the same things, right? So now it will be filling of memory gap by dome artificial memory. Treatment will be thiamine plus glucose. Then fourth we have is Huntington's disease. In this it will be like hunt will be there, so we can learn like hunt for cage, right? So cage is the CAG repeat. Okay, and hunt 4 means chromosome number 4. Okay, then we have hunt. So in this we have 4, like for example we have first grandfather, father, then it's us, right? So in grandfather, like there could be dementia, hallucination, or delusion. Okay, so it was like good. Then it comes to father, then it comes to you. Okay, so as generation advances, disease occurred with early with more symptoms, right? So this is how it happens with Huntington's disease. Then we have dementia with Lewy body. Okay, it's usually cognition. Then about approach, like how do we approach. And now we have come to meningitis, right? So what is meningitis? Let's see the approach. In this, first of all, we withdraw sample of CBC, LFT, KFT, culture, and then we do the fundus exam. In fundus exam we do lumbar puncture. Then treatment. In treatment, how we do is we give first we need to understand the things, and later on we will go to treatment. Okay, so first we understand. In this, first of all, there will be bacteria or pyogenic. Okay, that will be streptococcus. In this there will be cefamine, vancomycin, ampicillin. Okay, second we have virus or aseptic. In this it will be like enterovirus, ecovirus, COVID-19, herpes. Okay, so in this, then third will be TB. Clinical features will be in meningitis it will be headache, neck rigidity, seizures, fever, photophobia, cunning signs. All these things can be there. Okay, now comes the treatment part. IV ceftriaxone plus IV vancomycin we give. And when it's a culture report, in culture report we switch to specific or sensitive antibody. Okay, then we have IV steroid. In steroids we give decrease inflammation, decrease edema, and increase antibiotic permeability. Okay, So these were all the things regarding meningitis. Now we can know little bit about upper motor neuron and lower motor neuron. Okay, upper motor neuron, it will be like brainstem, neuron, spinal cord, and lower motor neuron, this axon terminate on skeletal muscle, right? So in this upper motor there will be hypertonia, hyperreflexia, there will be spasticity. Okay, there will be positive Babinski sign. Then we have abnormal plantar external reflex. Okay, and in this there will be flexor extension. That will be flexor will be upper UL, extensor will be LL, right? In lower motor it will be hypotonia, hyporeflexia, flaccidity, no spasticity, only flaccidity, and then in this there will be fasciculations. Okay, and in this there will be decrease in muscle tone. Okay, and also the investigation source will be MRI. Okay, then conus medullaris and coda equina. Okay, and this also we have already studied. Okay, medullaris is between T2 to L2, and equina is distal to L2, right? So these were the things which we have studied. And also just one more thing we can see, bulbar involvement and pseudobulbar palsy. In bulbar involvement it will be lower motor neuron and cranial number 9 to 12, and in pseudobulbar inappropriate crying, laughing, all these things can be there. Okay, now let's see, we need to know in meningitis we need to know the differences. For example, we have protein, opening, CSF and cells. Okay, and we have three things. We have bacterial, TB and viral, right? So only we will read differentiating features, right? Whenever you will have neutrophils, means bacteria is present, right? So in neutrophils CSF will be decreased because bacteria loves CSF, so bacteria will eat it, CSF will decrease and neutrophil will be there. Okay, then comes TB. In TB there will be cobweb, okay, for sure, so that will be lymphocyte. So okay, cobweb, CSF, and in this there will be opening pressure which will be higher, right? Then comes viral. In viral it will be protein, all will be increased, but CSF glucose will be normal in viral, and also in this there will be lymphocytes, right? Then then we have cryptococcal. In this there will be like HIV, Indian ink. Okay, in this also CSF will be decreased and PMN and neutrophil will be there. Then we have red CSF, that will be traumatic TEV, HSB, yellow red, and that will be SAH, xanthochromic. Okay, then we have a GBS. In GBS it will be what? Cells will be normal, protein will be more, and in this there will be albuminocytological dissociation. Okay, all these things are there. Then we have a thing which is Quincke's or scrotal needle. Okay, that means what? In this there will be lumbar puncture, spinal or epidural anesthesia, MTX or steroids, which will be intrathecal. Okay, then we have post lumbar puncture headache, that will be hydration before or after. Second, it will be proper seal plus do not change position. Third, it will be IV NSAID. Fourth, it will be caffeine. All these things are there. Now let's come to myasthenia gravis. That is what? In myasthenia gravis, this will decrease synaptic transmission, first thing. And in this there will be progressive weakness. It is a neuromuscular junction problem. And in this there will be myeloid cells in thymus, anti-ACH, anti-MuSK, anti-LRP4. All these things will be there. So myeloid cells we have, so it will be in thymus, which will serve as autoantigen. Okay, so 75% thymus involvement is there, so maximum will be hyperplastic, then thymoma. Okay, but usually they ask about thymoma because it is the most common mediastinal tumor. Okay, then we have ptosis, fatigue, face weakness, larynx weakness, musky voice, hot potato voice, arm or limb weakness. Then we have diaphragm weakness, respiratory failure, that will lead to death. Okay, now we have deep tendon reflex, that is novel in myasthenia, right? Then let's see the approach. In the approach, in myasthenia we can have curtain sign, we can have Kogan lid twitch, this is important. We can have eye speck test, which is ptosis, to improve. Then we have tension test, which is hydrophobium test. Okay, we can have single fiber electromyography, which is high sensitive. Okay, we can have repetitive nerve stimulation, decremental response, this we can see. CT chest to look for thymoma. We have antibody testing, which is the best test. AChR antibody. Okay, type 5 is more than type 2. Type 5 is hypersensitivity. Treatment we have is pyridostigmine, which is the drug of choice in myasthenia. Then we can give steroids, rituximab. Okay, in crisis we can give plasmapheresis, and at the end we can do is thymectomy. So they can also ask you what's the difference between myasthenia and Lambert. So in myasthenia, see, antibodies what we have is anti-ACH, anti-MuSK, anti-LRP4. This is associated with thymoma. This is the symptoms worsen by evening. Okay, this is the decremental response. It will be postsynaptic. Treatment will be pyridostigmine. But in Lambert, it will be like there is a channel problem, which is calcium channel problem. PQ type, anti. Okay. There it was thymoma problem. Here it will be small cell lung cancer, Lambert 1. Okay. It was used to worse by evening, but this will improve by evening, right? That was decremental, this will be incremental. That was postsynaptic, this will be presynaptic. That was pyridostigmine, this will be 3,4-DAP. So these were all the things. Now what is Duchenne muscle dystrophy? In this there will be child weakness, dystrophin gene, X-linked and early onset, right? But when it was Duchenne muscular dystrophy, right? But when it comes to Becken muscular dystrophy, then it will be later onset disease, right? And whenever we have acute disseminated encephalomyelitis, that means in this there will be measles plus measles vaccination. Okay, so these were all the things regarding things. And if you want to know some points, then I can tell you little bit about yeah, you can know about acute. In acute there will be dystonia, subacute akathisia. In tardive syndrome it takes months to year. Most common cause of second degree Parkinsonism, that will be neuroleptics. Okay, then we can have hemibellismus, that will be stroke. Then we can have two things, either essential tremor or it will be Parkinsonism. In essential tremors, it will be like we can have tremor, usually postural. We can have tone, that will be normal. We can have bradykinesia, rigidity, that will be absent. Then we can have deep brain stimulation. Okay, treatment will be primidone. So this was the essential tremors. And how to know about Parkinsonism? In Parkinsonism, that will be a resting tremor. Okay, in Parkinsonism, that will be a cogwheel pattern. Okay, so and also in Parkinsonism there will be bradykinesia, rigidity, all these things will be present. Okay, so these all things are there. And yeah, now let's move ahead with Parkinsonism. Okay, so we need to know like what it is, what are the features, what are the treatments. Okay, all these things we can see, and then we can move ahead. So in Parkinsonism causes, it could be anosmia. Okay, Brach staging. Okay, in this there is a classical is 3 cardinal symptoms: tremor, rigidity, akinesia, postural instability, all these things. And in this there will be cogwheel, clasp knife, lead pipe. Okay, cogwheel, clasp pipe, that was upper okay, upper one, and lead pipe was the lower one. Okay, so in this there will be like 4 to 6 hertz rest. Okay, and in this there will be risk of fall, gait instability. Okay, and yeah, in this there will be mask like face, expressionless face, turned Ian block, risk of second degree depression, fascinating gait, baby step movement, decreased arm swinging, stoop posture, decreased blinking, rapid tap forehead, keep on blinking, all these things will be there. Okay, then what is dementia? Dementia is this is also called as whenever it's repeat head trauma, that will be two things, either dementia or Parkinsonism. Okay, most common cause is idiopathic, which is Parkinsonian disease. Drug induced is antipsychotic, tetrabenazine, lithium, CCB. Then in this also it could be like we know Muhammad Ali, it was the one which had repeated head trauma. Then it could be Wilson, which is of Panda. Then eye of tiger appearance, Hailey-Worden-Sparks syndrome. Then we can have stroke, MPTP, methyl phenyl tetapyridine, CO, manganese toxicity, Parkinsonism plus syndrome, genetic. All these things can be there. And yeah, diagnosis clinical. Diagnosis will be levodopa plus carbidopa and dopa carboxylase inhibitor, dopa agonist, which will be pramipexole, romipexole, restless leg syndrome. Okay, and also in this there could be like rocket sign pull test, and also in this there could be like MAO-B, COMT. MAO-B is like salicylic, safagimide, okay, and dopa facilitator, amantadine. All these things we can use. And then what else we can use as treatment drug induced? We can use this benztropine, trihexyphenidyl, okay. Poor response with levodopa, that will be Parkinsonia plus syndrome. Young patient, tremors, some other symptoms. Then we can have Parkinsonia plus syndrome. In this there will be multi-system atrophy, MSA. There will be three things: ACP, autonomic cerebellar Parkinsonism, hot cross bun sign. In this there will be PSC, progressive supranuclear palsy, and Parkinsonism disease plus gaze effect. This will be PSP. Then we have DLB, dementia with Lewy body. In this there will be Parkinsonism plus Alzheimer's, right? Then we have corticobasal degeneration, Parkinsonism plus alien limb phenomena. Okay, if all the medical management usually fails, then what we do is DBS, deep brain stimulation, right? Then we have gait. Gaits are very important. In this it will be fascinating gait, Parkinsonism disease. And then we can have magnetic gait. Magnetic is frontal lobe. Circumduction or hemiplegia, that will be hemiplegia or stroke. Then we have wide base gait, that will be alcoholics or cerebellar disease or NPH, which is reversible dementia, right? Then we have scissoring gait. Yeah, then we have lurching gait or waddling gait. In lurching gait we can have DMD or BMD, that will be myopathies. Then we have dragging gait, that is polio. So all these things are there. Let's go ahead and see what is a stroke. Stroke is the one which has focal neurological deficit that persists for more than 24 hours. If symptoms resolve in less than 24 hours, that means it is showing a sign of TIA, transient ischemic attack. Okay, usually in stroke it will be unilateral limb weakness, that will be hemiplegia. Okay, in this there will be speech involvement impairment. Okay, in this it will be like ABCD2 score, which I also told in stroke. Age should be less than 60 degree. Sorry, age should be more than 60. Okay, BP should be more than 140/90. Clinical feature should be speech impairment or arm weakness. So all the we give one to A, one to B. For C we have two things: speech impairment 1, arm weakness 2. Then we have diabetes. In this also we have two things: diabetes and duration. Diabetes we give 1, and duration we have two things. If it's 10 to 59 minutes, 1. More than 60, it's 2. So by seeing this all the scores, we predict the risk of stroke in a patient, right? And so more the score, more will the chance of stroke in the future, right? Now comes the approach. So first what we do is NCCT first of all. Okay, in NCCT, in non-contrast CT, if it is normal, either it could be white or hyperdense, it could be black or hypodense, right? If it is white, to rule out hemorrhage, if it is white, then it will bleed. Okay, so treatment is supportive neurosurgery, right? And if it is normal, okay, then that means it will be ischemic, patient coming early. Okay, if it is black, that means it has gone ischemia, and the treatment will be thrombolysis, right? So this will be a treatment. So usually neurosurgery is for the white one only. Okay, now the main thing is window period of thrombolysis or mechanical thrombectomy. So the window period of thrombolysis is 4.5 hours, mechanical thrombectomy is 6 hours. Okay, so these were all the things regarding it. we must know what is burr hole, what is decompressive hemicraniotomy, okay, what is ischemia, what is hemorrhage, what is EDH, what is SDH, SAH, all these things we must know, okay. So now let us know the difference between three of them: EDH, SDH, and SAH. Right. First of all, where is EDH? EDH is epidural. Epidural means middle meningeal artery. This is the one which is the upper one, right? After that, there will be dura mater. Then comes subdural. In subdural, it will be what? There will be veins. Which veins? Bridging or vertex or emissary. All these veins will be there in subdural hemorrhage. Then comes arachnoid. After arachnoid, there will be subarachnoid hemorrhage. In subarachnoid hemorrhage, there will be villi, that will be berry aneurysm. Okay. Also in this, there will be xanthochromic CSF. So let's talk one by one. In three of them, there will be head trauma and hypertension. But in EDH epidural one, there will be biconvex. There will be MMA, middle meningeal artery. There will be lucid interval. Okay, that is talk or die interval, right? Then comes second is SDH. In SDH, it will be crescent shape and it will be vortex, right? Then comes SAH. Okay, that will be near to Sylvian fissure. In this, there will be berry aneurysm. Okay. In this, the berry aneurysm most common site is ACA side, and highest risk of rupture is PCA, right? That will be thunderclap headache, which is the worst headache of patient's life, right? So whenever you have EDH, epidural or subdural, whenever these two things are there, that means it is supportive oxygen BP control. In this, there will be burr hole surgery, okay, and that will be decompressive hemicraniectomy, okay. And whenever we have SAH, subarachnoid hemorrhage, in this there will be thunderclap headache, worst headache of patient's life. Treatment will be nimodipine, antihypertensive. In this, there will be two things: either it will be unruptured or ruptured. If it is unruptured, then it will be coiling. We just coil or clip. If it is ruptured, then ventriculostomy, right? Hesh and Hunt scale, that will be SH, right? So now, treatment of ischemic stroke. In this, there will be tissue plasminogen activator or LTPase. So how do we treat it? With the LTPase or TPA, right? So how much it should be? 0.9 mg per kg or stat IV. Okay. So what do we do is, or we can do is 0.9 mg into body weight directly. 10% will be the stat, 10% will be the infusion, which we give over 1 to 2 hours. For example, there is a person of 60 kg, 0.9 into 60, that will be 54. So 10% will be stat and 90% will be the infusion. So this is how we give, right? Then we know like Weber syndrome, that is third cranial nerve ipsilateral palsy. Then we have Benedict, that will be contralateral, and that also will be third, but in this there will be resting tremors, right? So now we know we have no maximum of the things, okay. Then we have middle cerebral artery, that will be hemiplegia, okay. In this, there will be no aphesis, and that will be dominant, and Broca's vernicus will be there. Whenever we have occlusion, MCA, middle cranial cerebral artery occlusion, so there will be M2 segments that has a inferior division, right? So in that, there will be first sensory aphasia, that will be vernicus, then comes fluent aphasia. So all these things will be there inside it, right? Let's talk about trigeminal neuralgia, that will be CBZ, carbamazepine. Then comes ALS, amyotrophic lateral sclerosis. Okay, this is a motor neuron disease. Okay, in this there will be superoxide dismutase, ALS. It is also involve the bulbar muscle, and in this there will be hexanucleotide repeat glutamate mediated toxicity. In this, there will be both upper motor and neuromotor features all will be there. It will be quadriplegia. In this, the higher mental function will be normal. Treatment will be riluzole, edaravone, right? These all things will be there. Caution could be like multi-generative motor neuron disease with muscle weakness and disability. So where it will be in absence of sign and symptoms. All these things can be there, right? So guys, maximum of the stuffs I have covered here, okay. And you can know some of the syndromes. Okay, like for example, you have Millard-Gobler syndrome, Weber syndrome. Okay, disorder Cushing triad, you can know all the important, some of them you can see. Then comes to syringomyelia, that is what, neck, shoulder, upper arm suspended. Okay, cavity in spinal cord. Clinical features: painless burn in hand. Okay, you will have central dissociated sensory loss, central cord syndrome. Okay, development delay in cervical cord. Okay, so body won't be able to move, and there will be, neck will be on the one side. All these things will be there. Then comes Battle sign. Battle means battle, BATTLE. B means behind and E means ear. So behind the ear, you will have a basic skull fracture. Then comes raccoon eyes. Raccoon eyes is cranial fossa, which is amyloidosis. Then we have halo sign, which is CSF rhinorrhea. Okay, foramen magnum syndrome. All these things are there. Okay, then I will be telling you some of the important points. Okay, which are important. And yeah, I think you remember till now. Let me also tell you, in conus medullaris, the knee jerk will be preserved, and in equine it will be negative. Okay, now I will tell you some points which are the very important. Whenever you have normal tendon reflex, tendon is normal, but there is muscle weakness. That will be what? Myasthenia gravis, right? Whenever you have dementia, but it is reversible dementia. It is reverse then SACD, which will be B12. Okay, this is important. Then whenever you have extensor plantar reflex on pitching gastrocnemius muscle, there is a gastrocnemius muscle. Okay, but you have pitching, or and the reflex is coming external plantar reflex, then it will be Gordon, right? Then comes Horner syndrome. I told you about Horner syndrome, that will be Punjabi meal. Punjabi ptosis, meals means meiosis. Okay, so like this, EAL, all these things were there. Inability to recognize face, you can't recognize the face. Then that is prosopagnosia, in which occipita will be more than temporal. Prosopagnosia, okay, inability to recognize face. Then comes complete transaction of, okay, complete transaction of SC. That means what? There is a loss of bladder control, loss of senses, movement below the level of incision. So there will be loss of all the things if you have cut SC, right? Then if you have ipsilateral loss of tactile, vibration and positional, and contralateral pain and temperature. See, the pain and temperature contralateral, and ipsilateral, tactile, vibration, position, all these things are there. That means that is Brown-Sequard syndrome, right? Okay. Then comes gap. In this, what will be there? You have chorea. Chorea is also called as breakdance. Chorea means it will be chordate nucleus. Okay. Whenever you have athetosis means slow dance. Okay. Slow dance means what? In this, there will be putamen or globus pallidus, right? So this also we remember is gap. Okay. P means putamen, A is athetosis. Okay. G means globus pallidus, right? Then we have hemibellismus. Hemibellismus means fingering or jerky. That means that will be subthalamic, right? So now let's go to some more points. In this, there will be pendular knee jerk in left hand. So whenever you have pendular knee jerk, right? You have knee jerk, that is pendular. So it will be in left hand of what? In left hand of cerebellum, right? So now whenever you have ataxia, areflexia, ophthalmoplegia, that will be what? Miller-Fisher, right? Whenever you have semi-purposeful, non-repetitively, random distributed movement, that will be chorea, okay, breakdance, and which will be in a chordate nucleus. Whenever you have CSF, right? CSF glucose, so that will be what? 2/3 of blood glucose, that will be 60 to 80 milligram per deciliter, right? CSF glucose, 2/3 of blood glucose. Okay, now there are signs. Kirohan-Voltman sign. Okay, in this there will be ipsilateral will be there in both, but one will be Babinski, second will be hemiparesis. Kirohan-Voltman sign, Babinski, hemiparesis. ठीक? Then is Listeria meningitis. So in dugout source for Listeria meningitis, it will be ampicillin. Okay. Then you have SSPE, that means it is measles, right? Whenever you have normal cells with increased protein, okay. Also, I told you about protein in before also, but here the protein will be increased, but cells will be normal, okay. Whenever you have this, then it will be what? It will be GBS, that will be albuminocytological dissociation. Protein will be increased, cells are normal, okay. Now whenever you are epilated third nerve palsy and crossed hemiplegia, third nerve palsy is there, epilated, and hemiplegia is closed, that means it is Weber, okay. McDonald's criteria used for multiple sclerosis. Dementia, dementia whenever it's reversible, okay, then it will be hypothyroidism, okay. In reversible dementia it will be hypothyroidism. Whenever you have painless burn is there, which is painless, okay. You are not having any pain but burn is there, that is syringomyelia, okay. You have axillary franklin, okay. Axillary franklin, that will be neurofibromatosis type 1. Whenever you are Lewy body, that will be seen in Parkinson disease or dementia with Lewy body. Most common site of brain hemorrhage, putamen, okay. Mathematical calculations are controlled by whom? Parietal lobe, which is dominant, okay. Cut off for TIA will be for how much time? 24 hours. So this was all about the CNS. I have tried my best to cover the whole CNS in as much as less time, in a very concise way. I hope you liked this audio, and we meet again. Thank you guys.